Hello! In this video, we'll be discussing about aminoglycosides and spectinomycin. To start off with, what are aminoglycosides? Aminoglycosides are bactericidal inhibitors of protein synthesis that interfere with ribosomal function. These agents are useful mainly against aerobic gram-negative microorganisms. The aminoglycosides group include streptomycin, neomycin, kanamycin, amikacin, gentamicin, tobramycin, cisomycin, nitylmycin, and others. These drugs are most widely used in combination with a beta-lactam antibiotic in serious infections with gram-negative bacteria. Also, in combination with vancomycin or a beta-lactam antibiotic for gram-positive endocarditis and for the treatment of tuberculosis. Aminoglycosides have a hexose ring, either streptidine in streptomycin or 2-deoxystreptamine in other aminoglycosides, to which various aminosugars are attached by glycosidic linkages. There is also the streptose and N-methyl L-glucosamine, thus making the streptobiosamine. They are water-soluble, stable in solution, and more active in alkaline than at acid pH. Several types of antibiotics inhibit bacterial protein synthesis. The bacterial ribosome is composed of the 50S and 30S ribosomal subunit, which is different from the 80S ribosomes of eukaryotes, making it a target for selective toxicity. Most of the antibiotics bind either to the 30S or the 50S subunit of the ribosome, thereby interfering with the protein synthesis. Aminoglycosides such as streptomycin bind to a protein in the 30S ribosomal subunit and interfere by inhibiting protein synthesis and causing the misreading of the mRNA. Different aminoglycosides bind to the different target proteins in the 30S ribosomal subunit. These antibiotics distort the ribosomes so that misreading of the code in the mRNA occurs and protein synthesis cannot continue. Protein synthesis is inhibited by aminoglycosides in at least 3 ways. First, the interference with the initiation complex of peptide formation. Second, misreading of mRNA, which causes incorporation of incorrect amino acids into the peptide and results in a non-functional protein. And third, breakup of polysomes into non-functional monosomes. These activities occur more or less simultaneously, and overall effect is irreversible and leads to cell death. Bacteria can be resistant to aminoglycosides by, first, production of a transferase enzyme or enzymes inactivates the aminoglycoside by adenylation, acetylation, or phosphorylation. This is the principal type of resistance encountered clinically. Number 2. There is impaired entry of aminoglycoside into the cell. Number 3. The receptor protein on the 30S ribosomal unit may be deleted or altered as a result of mutation.
The pharmacokinetics of widely used and of investigated aminoglycosides, namely kanamycin, gentamicin, tobramycin, amikacin, and nitylmycin. In normal volunteers and in patients with physiological states and disturbances known to alter their disposition are critically examined in view of recent developments. Aminoglycosides are absorbed very poorly from the gastrointestinal tract, and also they are neither protein-bound nor biotransformed. They are highly polar compounds. Due to the almost exclusive excretion from the body by glomerular filtration, the elimination rate of aminoglycoside antibiotics is greatly affected by impairment of renal function. The mathematical relationships between pharmacokinetic parameters and renal function indicators are tabulated and discussed. The predictive potential of monograms can be greatly improved by taking into consideration some physiological parameters such as sex, age, lean body mass, hematocrit, and characterization of disposition kinetics by multi-compartment models. The normal half-life of aminoglycosides in serum is 2 to 3 hours, increasing to 24 to 48 hours in patients with significant impairment of renal function. In the neonatal period, the absorption rate after intramuscular injection appears to be faster than reported in adults, and the volume of distribution is significantly larger. The major pharmacokinetic difference between neonates, infants, and adults is a slower elimination. The volume of distribution per kilogram of body weight is relatively smaller in obese subjects, and in dehydrated patients than in normal subjects, and can lead to overdosing when dosages are calculated on the body weight basis. All aminoglycosides have the danger of ototoxic and nephrotoxic. Ototoxicity and nephrotoxicity are most likely to be encountered when the therapy is more than 5 days, higher doses in the elderly, and in the setting of renal insufficiency. Loop diuretics and nephrotoxic antimicrobials can potentiate nephrotoxicity. Ototoxicity results auditory damages like tinnitus, high-frequency hearing loss initially, or vestibular damages with vertigo, ataxia, and loss of balance. Most ototoxic causing agents are neomycin, kanamycin, and amikacin. Nephrotoxicity results in rising serum creatinine levels or reduced creatinine clearance. Most nephrotoxic causing agents are neomycin, tobramycin, and gentamicin. In the very high doses, aminoglycosides can produce Kurata-like effects with neuromuscular blockade that results in respiratory paralysis. The paralysis is usually reversible with calcium gluconate or neostigmine. Aminoglycosides are mostly used as against aerobic gram-negative bacteria, especially when the isolate may be drug-resistant and when there is suspicion of sepsis. They are usually used as combination with a beta-lactam antibiotic to extend coverage to include potential gram-positive pathogens and to take advantage of the synergisms between these two classes of drugs.
Streptomycin was isolated from a strain of Streptomyces griseus. The antimicrobial activity of streptomycin is typical of that of other aminoglycosides, as are the mechanism of resistance. Streptomycin is mainly used as a second-line agent for treatment of tuberculosis. The dosage is 0.5 to 1 gram per day, given intramuscularly or intravenously. In plague, tularemia, and sometimes brucellosis, streptomycin is given intramuscularly in combination with an oral tetracycline. Penicillin plus streptomycin is effective for enterococcal endocarditis and 2-week therapy of viridal streptococcal endocarditis. Gentamicin has largely replaced streptomycin for this indication. The adverse effects of streptomycin are fever, skin rashes, and other allergic manifestations. These occur most frequently with a prolonged course of treatment. The most serious toxic effect with streptomycin is disturbance of vestibular function, vertigo, and loss of balance. Streptomycin given during pregnancy can cause deafness in the newborn and therefore is relatively contraindicated. Gentamicin is a mixture of three closely related constituents, C1, C1a, and C2, isolated from Micromonospora purpurea. It is effective against both gram-positive and gram-negative organisms, and many of its properties resemble those of other aminoglycosides. Gentamicin sulfate inhibits in vitro many strains of Staphylococci and coliforms and other gram-negative bacteria. It is active alone, but also as a synergistic companion with beta-lactam antibiotics against gram-negative rods that may be resistant to multiple other antibiotics. Like all aminoglycosides, it has no activity against anaerobes. Streptococci and enterococci are relatively resistant to gentamicin, owing to failure of the drug to penetrate into the cell. However, gentamicin in combination with vancomycin or penicillin produces a potent bactericidal effect, which in part is due to enhanced uptake of drug that occurs with inhibition of cell wall synthesis. Gentamicin is used mainly in severe infections caused by gram-negative bacteria that are likely to be resistant to other drugs, especially P. aeruginosa, Enterobacter species, Serratia marcescens, Proteus species, Acinetobacter species, and Klebsiella species. Creams, ointments, and solutions containing 0.1 to 0.3% gentamicin sulfate have been used for the treatment of infected burns, wounds, or skin lesions and in attempts to prevent intravenous catheter infections. 10 milligrams can be injected subconjunctivally for treatment of ocular infections. Meningitis caused by gram-negative bacteria has been treated by the intrathecal injection of gentamicin sulfate. The adverse effects of gentamicin are nephrotoxicity, which is usually reversible, ototoxicity, which tends to be irreversible, manifests itself mainly as vestibular dysfunction. Loss of hearing can also occur. Tobramycin has an antibacterial spectrum similar to that of gentamicin. Although there is some cross-resistance between gentamicin and tobramycin, it is unpredictable in individual strains. Tobramycin has almost the same antibacterial spectrum as gentamicin with a few exceptions. Gentamicin is slightly more active against S. marcescens, whereas tobramycin is slightly more active against P. aeruginosa. Enterococcus faecalis is susceptible to both gentamicin and tobramycin, but E. faecium is resistant to tobramycin. Gentamicin and tobramycin are otherwise interchangeable clinically. The adverse effects of tobramycin are ototoxicity and nephrotoxicity. Nephrotoxicity of tobramycin may be slightly less than that of gentamicin. Amikacin is a semisynthetic derivative of kanamycin. It is less toxic than the parent molecule. It is resistant to many enzymes that inactivate gentamicin and tobramycin and therefore can be used against some microorganisms resistant to the latter drugs. The adverse effects of amikacin are nephrotoxicity and ototoxicity, particularly for the auditory portion of the 8th nerve.
Nettlemycin. Nettlemycin shares many characteristics with gentamicin and tobramycin. The addition of an ethyl group to the 1 amino position of the 2-deoxystreptamine ring sterically protects the nettlemycin molecule from enzymatic degradation. Nettlemycin may be active against bacteria that are resistant to gentamicin and tobramycin. Neomycin and kanamycin. Neomycin and kanamycin are closely related. Paromomycin is another member of this group. These drugs are active against gram-positive and gram-negative bacteria and some mycobacteria, although Pseudomonas aeruginosa and Streptococci are generally resistant. Since it is poorly absorbed in the gastrointestinal tract, this group is now limited to topical and oral use. The structure of neomycin and kanamycin. Spectinomycin is active in vitro against many gram-positive and gram-negative organisms. It is useful for the treatment of gonorrhea infections. It is administered and rapidly absorbed intramuscularly. Adverse drug reactions include possible nephrotoxicity and anemia in some rare cases. Below is its structure.